Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're covering a vascular topic that often flies under the radar: phlebitis and thrombophlebitis. We'll break down the basics, who's at risk, how to diagnose, and how to manage it. Let's jump right in. Alright, let's start with the basics. Phlebitis refers to inflammation of a vein, and thrombophlebitis takes it a step further by adding the presence of a clot. These conditions most commonly affect the superficial veins of the lower extremities. However, when the inflammation and thrombosis is present in the axial veins, which are the great saphenous, accessory saphenous, and small saphenous veins, this is called superficial vein thrombosis. This has a similar level of seriousness as what we give DVT, which is deep vein thrombosis. This is due to the recognition that thrombosis of the axial veins can be associated with the DVT and PE at the time of diagnosis or lead to subsequent thromboembolism. Now, let's talk about who's most at risk. Superficial phlebitis and superficial thrombophlebitis are commonly seen in patients with varicose veins, which cause venous stasis and increase clot risk, recent venous procedures, such as sclerotherapy or venous ablation, prolonged immobility, you want to think of hospitalization or long flights or post-surgical patients, IV catheter use, this could be someone who had an IV or an IV drug user, pregnancy or estrogen therapy, so these cause hypercoagulability. Prior vein thrombosis also is a risk factor due to endothelial damage, and other hypercoagulable states, including factor V Leiden mutation, acquired thrombophilic states, and malignancies. Now, how do these conditions show up in clinic? Uncomplicated cases present with localized pain, tenderness, induration, and redness along a superficial vein. Patient may also have a palpable cord-like structure, and if this persists despite elevation of the extremity, then this is suggestive of presence of a thrombus. And just a little note here, unlike DVTs, superficial phlebitis doesn't usually cause significant swelling of the entire limb, and systemic symptoms like fever are not common unless there's an associated infection. The diagnosis of phlebitis and thrombophlebitis is mainly clinical. If you see the signs and symptoms in a patient with risk factors, you're probably dealing with superficial phlebitis or thrombophlebitis. However, imaging is needed if upon initial presentation there is concern for a coexistent DVT and to evaluate the location and extent of thrombosis. If there's concern for extension that is greater than what would be expected from phlebitis or thrombophlebitis, and if there's evidence or clinical progression during a period of follow-up. In these cases, a duplex venous ultrasound can confirm the presence of thrombosis as well as its location and extent. Now, the management depends on the severity and whether DVT is involved. For uncomplicated cases, the aim is to alleviate symptoms, decrease inflammation, and prevent propagation of thrombus. Supportive care is the mainstay, which includes warm or cool compresses, extremity elevation, and NSAIDs. Compression stockings can be encouraged if they are not contraindicated, and patient should remain ambulatory if possible. You'll want to follow up with the patient within 7 to 10 days to reevaluate for resolution or progression. Any worsening or extension of signs should prompt a duplex venous ultrasound. A few additional notes here in the management section are that antibiotic treatment is not indicated unless there are signs of infection, such as high fever or purulent drainage, and anticoagulation is suggested for patients with superficial vein thrombosis at increased risk for venous thromboembolism. Regarding prevention, since many cases of phlebitis and thrombophlebitis occur due to venous stasis and endothelial injury, prevention is key. You want to encourage ambulation when possible in post-op and hospitalized patients. Use compression stockings for those with venous insufficiency or prolonged standing jobs. Minimize IV catheter dwell time and rotate sites frequently. And lastly, identify and treat underlying hypercoagulable states if patients have recurrent thrombosis. Here's a quick mnemonic to help you remember the key risk factors. The mnemonic is VEINS, V-E-I-N-S. The V stands for varicose veins. E stands for estrogen therapy or pregnancy. I for immobilization, such as surgery, travel, or hospitalization. N for needle use, like in IV drug use or IV catheters. And S for surgery or trauma to veins. Now, before we get some practice in, here are some clinical pearls. Number 1. Superficial phlebitis and thrombophlebitis are usually self-limited, but if the axial veins are involved, this is called superficial vein thrombosis and can be associated with concurrent DVT and PE at initial presentation. Make sure to look at these more carefully. And number 2, if an IV site becomes red and painful, discontinue the infusion, remove the catheter, and monitor the insertion site as well as the associated proximal vein. All right, here are a couple of clinical questions. Question 1. A 45-year-old woman presents with pain to her medial calf that started 2 days ago. She denies fever or shortness of breath. Her past medical history is significant for varicose veins and prolonged standing at work, but otherwise unremarkable. Vitals are also unremarkable. Physical exam reveals localized erythema and tenderness over the medial calf. Varicose veins are noted underlying the erythema. No areas of induration are noted. Which of the following is the most appropriate initial treatment? Is it A, start full dose anticoagulation, B, reassurance and observation, C, prescribe compression stockings and NSAIDs, or D, initiate IV antibiotics? I'll give you a couple of seconds. If you chose C, prescribe compression stockings and NSAIDs, you are correct. This is a classic presentation of uncomplicated superficial phlebitis. Supportive care is the first-line treatment. Question 2. A 45-year-old woman presents to the clinic with pain to her right forearm. She was hospitalized last week for dehydration and had an IV placed for fluids. She denies fever, chills, or systemic symptoms. Exam reveals redness, swelling, and tenderness along the course of the IV insertion site. A palpable cord is also noted. Which of the following is the most appropriate initial management? Is it A, apply warm compresses and prescribe NSAIDs, B, start empiric IV antibiotics, C, order a venous ultrasound to rule out DVT, or D, initiate full dose anticoagulation? If you chose A, apply warm compresses and prescribe NSAIDs, you are correct. This presentation is consistent with superficial thrombophlebitis due to the recent IV catheter, the redness, swelling and tenderness, and the palpable cord. Supportive management with warm compresses, NSAIDs, and elevation is typically sufficient. Antibiotics are unnecessary unless there are signs of infection. And a venous duplex ultrasound is reserved for cases where there is concern for extension into the deep veins. Great job! That wraps up today's episode on phlebitis and thrombophlebitis. While often a benign and self-limited condition, it's important to recognize when further evaluation or treatment is needed, especially when a thrombus is near a deep venous junction. As always, knowing when to reassure versus escalate care is key in primary care practice. If you found this helpful, don't forget to subscribe so you never miss an episode. And as always, this is a Pro PA podcast, where future pros in medicine are made. See you next time.